So, good evening, everyone. First of all, on behalf of Intas Pharmaceuticals and the Nexa division of Intas, I, Dr. Sandesh Vodkar, very warmly welcome you all to yet another episode of Lipitas Lectures. The objective of this series, Lipitas Lecture, is to explore evolving cardiometabolic insights with the country's leading experts in the field of cardiology. In this episode, also, our distinguished speakers will address two critical dimensions of cardiovascular care: the need for optimal antithrombotic strategies in complex high-risk ACS patients to improve clinical outcomes while minimizing the bleeding and the importance of evolving. The second talk will be focusing on the evolving personalized lipid-lowering approaches as new evidence and targets emerge to better management of residual cardiovascular risk. So with this and without much ado, I would like to welcome our both the speakers. So our first speaker is Dr. Devabrata Roy. He is a senior interventional cardiologist at NHRT IICS, Kolkata. He serves on the governing body of the World Heart Federation and the Executive Committee of Cardiological Society of India, with key interest in preventive cardiology, lipidology, hypertension, and interventions. He has led award-winning CSI projects recognized by WHF and ACC, and he has guided multiple international award-winning theses and has approximately 120 publications to his credit. And he also contributes to major CSI guidelines on STEMI, COVID-19, heart failure, dyslipidemia, and antithrombotic therapy. So welcome, Dr. Roy. Our second speaker is Dr. Kamal Sharma. Dr. Kamal Sharma is a senior interventional cardiologist with more than 20 years of experience in angioplasty, stenting, and structural interventions. He is the discoverer of the winking coronary sign. He holds a dual DNB degrees in medicine and cardiology in addition to MD and DM. He practices at Sal Hospital and UN Mehta Institute, and he's also the faculty at BJ Medical College, Gujarat University. Dr. Sharma is also a recipient of 22 gold medals, CSI Oration Award in 2022, and Excellence Teachers Award. Dr. Sharma has authored 8 books, around 290 publications, and more than 12,000 citations. And uniquely, is the only cardiologist to clear IAS, IPS in the first attempt, and MIT certified in healthcare and executive management from the University of Virginia. So, welcome, Dr. Sharma. And now we will move on to the first talk. So, it's over to you, Dr. Roy.
Yeah, can I share my slides?
Sure,
Yeah.
sir.
Yeah, it is visible. My slides are visible.
Yes, sir. They are
Yeah.
visible.
Okay. Thank you, Dr. Warkar, for the kind introduction. But there is a slight mistake. I'll be talking on triple hypolipidemic therapy. It's not the antithrombotic therapy and its justification in high-risk acute coronary syndrome patients. The acute coronary syndrome patients who present with heart failure, S3 gallop on auscultation, and prominent ECG signs in form of ST segment depression and elevation of troponin I. So these are the high-risk patients who will require either an early intervention if it's non-STEMI, or will require a primary PCI if the patient belongs to the STEMI group. Now, as we all know that in cases, all the cases of coronary artery disease, the lipid, it is the LDL that matters most. And it has been shown that with lipid lowering therapy and resultant decrease in LDL, there is both reduction in MACE as well as beneficial regression in plaque morphology as manifested by increase in fibrous cap thickness, calcification, and decrease in plaque volume or lipid core burden index. There is also the studies that had shown that there is a positive correlation between percent change in plaque volume, which is the most important marker in assessing the severity of a lesion with follow-up LDL cholesterol level. We know that the early initiation of statin in such cases is beneficial, whether we start it within 24 hours or we start it within 72 hours. It doesn't matter. Any early initiation within 72 hours is beneficial. Uh, that was for the statin therapy. What about the PCSK9 inhibitors? We also have several studies of the PCSK9, both the alirocumab and the evolocumab, shown that if it started within 24 hours or even before primary PCI, it gives benefit in terms of reduction in events. In fact, these therapies, when combined with high intensity statin, it can induce dual or even triple regression. So what is the triple regression? It is reduction in plaque atheroma volume, reduction in lipid core burden index, and increase in fibrous cap thickness. However, in IVA studies, we couldn't demonstrate any significant difference in plaque composition between those who are receiving this combination of high-intensity statin and PCSK9 inhibitors vis-a-vis those who receive only high-intensity statin. Now, with all this, so are we justified in starting a patient of acute coronary syndrome very early? I think with the data that we have, early initiation is justified. But second, whether we'll strike strong, that is, whether in such cases we try a triple combination of high-intensity statin, ezetimibe, and a PCSK9 inhibitor or a, siRNA agent like inclisiran. Now, if you can see from this, in patients of acute coronary syndrome who has undergone PCI, the maximum hazard ratio for MACE occurs within 1 week. In fact, more than 50% of patients suffer a MACE within 1 week. For high-dose statins in ACS patients, the benefit, as you can see from the curve on right-hand side, it starts very early as compared to the who have not received statins or who have discontinued statins. There is a market benefit achieved in the patients undergoing statin therapy. And this occurs very early, almost within first week of the event. Now, what happens with the PCSK9 inhibitor? The hypothesis behind using PCSK9 inhibitor is that it brings down LDL to a remarkably low level. And this is reflected in a beneficial change in plaque morphology. It reverts a vulnerable plaque to a stable plaque. Now, if you can see this data from Fourier and Fourier-Olet trial, the reduction in LDL to the optimal level as per standards of PCSK9 inhibitor trials, it takes at least 12 weeks. And if you see the plaque regression, it takes months. It takes months for plaque regression to happen. And this is revealed by all the PCSK9 inhibitor trials who has undergone IVAS. Similarly, in patients who have high intensity statin, it is again from the plaque regression takes somewhere between 18 to 24 months to happen. So plaque regression may not be the main event or may not be the main point of consideration when you are looking at a patient of high risk ACS very early during the course of the disease. Now, a recent meta-analysis has shown, it's a meta-analysis of 23 studies. They have shown that to reduce your plaque athyroma volume by even 1%, it reduces MACE by 14 to 25%. But this reduction in plaque athyroma volume is mediated by the duration of the therapy, as I have shown in the last slide. And it may be post-dated to MACE reduction. You remember the trials that I showed with high-intensity statin, where the benefit as per MACE reduction is manifested within days of initiation of therapy. And plaque regression takes months, and with both high-intensity statin or PCSK9 inhibitors, it is not an instant event. And this is caveat 2. Where is the mortality benefit? With high-intensity statin, we know it can lead to stabilization of the plaque, and it can lead to mortality benefit also. But with PCSK9 inhibitors and with siRNA inhibitors, what mortality benefit? If you look at the recent meta-analysis by Wang, as recent as in 2022, this paper is published, with both alirocumab and evolocumab, there is no significant benefit in all-cause mortality and cardiovascular mortality. Both of them reduced MACE, which is a composite of cardiovascular death, myocardial infarction, stroke, and coronary revascularization. But this is mainly driven by a decrease in stroke and coronary revascularization. Of course, evolocumab had a positive effect on myocardial infarction. Now, somebody might tell about the Fourier trial, which has shown that the long-term data where there is some mortality benefit. But that data has been challenged, and this is a paper that has been published in no other journal than BMJ Open, where they have asked for the recall of the Fourier trial data because they have found after re-adjudication of the data that deaths of cardiac origin were numerically higher evolocumab group. They in fact asked for a complete restoration of the Fourier trial data. What appears to be the last nail is in the coffin is a recent paper published in Lancet in September 2025, which has shown that among patients who underwent CABG, evolocumab did not reduce the saphenous venous graft disease at 24 months following the indexed surgery, despite substantial LDL cholesterol lowering. In fact, Dr. Verma, who was the principal investigator for the trial, has told that his trial results suggested that LDL lower cholesterol lowering eh, per se does not affect the graft failure. Rather, it might be remodeling or thrombotic events or inflammation. So, is inflammation the missing link? We know from earlier trials like Jupiter and Prove It that a concomitant decrease in HSCRP to less than 2 milligram per DL, along with a decrease in LDL cholesterol to less than 70, leads to maximum benefit. In other trials involving hypolipidemic agents other than statins like prominent, reduce it, and strength, a meta-analysis of all the three involving a total of 31,245 patients published as recent in Lancet 2023 has shown that the residual cholesterol risk manifested by the LDL level is neutral for MACE or is of low magnitude for cardiovascular death and all-cause death. Whereas the residual inflammatory risk as manifested by HCRP is significantly associated with incidence MACE, cardiovascular mortality, and all-cause mortality. To cap it all, this is an analysis, secondary analysis of Fourier from Bohula, and you can see it has a very interesting finding. So even if your cholesterol, LDL cholesterol is reduced below 20, but your HSCRP is more than 3, the primary outcome is 13% and secondary outcome is 8.9%. So when you're looking at a patient with acute coronary syndrome, where we know there is an exponential inflammatory process goes on at that time, we have to give importance, we have to give consideration to the inflammatory process and not to LDL cholesterol only. Unfortunately, the PCSK9 inhibitors have shown to have no effect on HSCRP reduction, though with inclisiran, a bi-yearly dose can affect only a 16.7% reduction in HSCRP, and there are some agents like bempedoic acid also, which have some effect on HSCRP reduction. But it is the statins which has the maximum effect on HSCRP reduction. So this is the thought that led Cardiological Society of India devise this algorithm for patients of acute coronary syndrome. So we advocated for starting such patients on a combination of atorvastatin, or moderate dose intensity statin with ezetimibe, or in high dose, not moderate dose, in high dose intensity statin with ezetimibe. Check the lipid level at 4 weeks. See whether it is within the goal of less than 55, and then consider adding other agents. This is because of all the drugs, as shown by the previous trial that I've depicted in my earlier slide, it is only the statin that can produce early benefit, not PCSK9, not inclisiran. So, to end, I'll want to remind you all of what Arthur Graham, who has been a member of the ESC Guideline Committee on AIDS, he told that half of the world can't even afford statins. We have to be a little realistic. We need not jump on more costly agents before trying out more affordable agents that we have. Thank you for your kind hearing.
Thank you so much, sir, for sharing those critical insights and the practical implications for having the triple combination in the management of high-risk ACS patients. With this, we will move on to our second talk. And for this, I would like to invite Dr. Sharma. Over to you, sir.
Good evening, everyone. Thank you very much for a wonderful session by Dr. Debabrata. He spoke beautifully about the inflammation being the missing link. And I also strongly believe that that's the case because we had three patients who had acute coronary syndrome despite familial low LDL of less than 2. And so it's multi-risk factor. We all understand that. But I think lipid remains a big challenge which needs to be addressed. All said and done, out of 10 risk factors that define uh, attribute the risk of 90% times, it's the lipids, which is important to address and needs to be managed as one of the modifiable risk factors that we know. You can't stop aging, you can't change gender, at least biologically, but you can surely modify lipids. So I'm going to take you through changing trends in lipid management. So basically, dyslipidemia is a crisis that's looming large. And recently we had the phase 1 trial of CRISP-Cas9, where they have actually inserted a gene with a gene therapy published in Circulation just 3-4 days back in patients with homozygous familial hypercholesterolemia targeting NGPTL3, and they could reduce LDL by 88%. So I'll continue from where Dr. Debabrata Das left, from the quote that 50% of the world can't afford, but as of the statins, but as the science evolves and the gene therapy comes in and it becomes cheaper, probably one shot, and we'll be able to manage lipids like a vaccine. So till that happens, we are here for a decade or so to look and chase dyslipidemia, which fuels 4.4 million CV deaths annually, with LDL accounting for 58% of attributable risk, according to 2022 GBD study. Recent cohort reveals 45% of high-risk individuals fail the LDL goals, linking to 1.5 times MACE increase over 5 years. Hypertriglyceridemia surges 15% in urban versus rural, exaggerated by metabolic syndrome. Prevalence exceeding 30% in adults over 40. Lipolitile more than 50 correlates with 2.5 times plaque regression, progression, and demanding integrated approach, which again Dr. Devarat showed from the IVA studies. ASCVD incidence rises by 20% in South Asian Indians, especially due to genetic predisposition of small, dense LDL, and hence our ethnic variability and susceptibility. So statins have revolutionized, there is no doubt about it, in nearly one-third of the landmark trials where major events were reduced. And despite decades of progression, residual ACVD remains, driving need for novel therapies, as I was discussing about the late-breaking trial of the genetic modification of NPTL3. 2019 and 2022 guidelines from ESC and ACC respectively introduced a paradigm of risk-based intensity, and now we know the target's going below 55. Even the CSI guidelines have talked about bringing it down aggressively. Prescription trends show more than 200% rise in non-statin use. Hence, the need for combination, residual risk, and inflammation, as was mentioned beautifully by Sir, is again something that we need to look beyond. And in India, dyslipidemia is a silent epidemic. Earlier onset, higher TG, a typical lipid profile, and under treatment persist as a big problem. So we need to focus beyond LDL. It's not just LDL, it's as they call non-HDL cholesterol components, which includes TG, ApoB, and inflammation, and lipolittle A. Non-HDL ApoB outperform LDL-C in both diabetic and metabolic syndrome. Lipolittle A is gaining prominence. Triglyceride-rich remnant, small dense NDL contribute to residual risk. PCSK9 regulates LDL receptor degradation, and hence its inhibition is one of the new therapy that's being targeted. And lipidomics and metabolomics are now enabling fine-grained profiling for precision lipidology. So guidelines, there has been shift, new goals. 2019, it was 55 LDL over the better, and for very high risk was less than 40. 2022, focused risk stratification with cumulative lifetime LDL goal exposure, the lipid burden, as they call, per year, you sum it up, and the moment you cross a threshold of 150 millimoles, which is almost 50,000 plus of milligram per deciliter of LDL as a summation per year, that's when you get an acute coronary event, as they mentioned. Sequential high intensity with ezetimibe and PCSK9 in one strategy. Bempedoic inclisiran formally added to therapeutic ladder of statin intolerant cases. A new guideline shift has focused to absolute reduction than percentage alone, with Indian guidelines and Indian lipid management increasingly being hybridized, blending both ESC as well as local affordability. So guideline genome from 2018 to 22, we now know that Indian CSI in 2023 adopted these local epidemiology. And way back, we were talking about less than 100 in low risk also. And transitional theme is now evolving from population based to individualized thresholds, harmonizing global standard with regional nuances. 2023 ESC, there is precision now in management of dyslipidemia. Enhanced focus is there on polygenic risk scores, integrating 20 plus SNPs for 15% better CVD prediction models. Updated algorithms are now talking and mandating ezetimibe as an add-on if the LDL is still more than 70 beyond statin, yielding further reduction per deliver trial subset. Women are again brought down with a specific focus to bring about the gender biasness being taken care of. Gestational dyslipidemia and ASCVD harbinger has been identified with 1.8 times the risk if TG is more than 200, as per the 2023 longitudinal data. In LI also talks about 50 and 70, addressing twice the prevalence. But it's the CSI which has already talked about it very aggressively for quite some time now. Safety spotlight is of monitoring for statin intolerance with genotyping to reduce myopathy by 40%. And the setting stage for 2025 update, where we are talking about silencer mRNA integration, which amplifies the guideline efficacy in refractory cases. So Lipid Association has already touched upon targets of less than 100 for LDLC goals, for low risk 70 for high risk, less than 50 for very high risk, and less than 30 for extremely high risk, as per the subclinical atherosclerosis detection by carotid intima media thickness. Lifetime ASCVD quantification for 10-year model is something that they utilize, and hence incorporation of non-conventional factor like the family history, HSCRP, metabolic syndrome score of more than 3 for an upstaging risk by 25%, where the treatment cascade would then require high dose statin like atorvastatin 40 or 80 milligram with 90% adherence goal via digital reminders. The evidence base has been modeled by 35% MACE reduction in simulated Indian cohorts, validating the aggressive thresholds against Western data. And then bridging innovation has been talked about by paving way for PCSK9 access subsidies addressing 70% cost barriers in low resource setting, which we also now know with the GST reduction taken off, the therapies become cheaper, and it's expected to further become cheaper as the time goes by. So coming back to the treatment goals for low intensity, how this has evolved in total cardiovascular risk across categories. This is how it is. And as the various trials, that how you look at them. If you look at score two or a trial of the risk score of 2 to 10%, you fall into moderate risk. If it's less than 2%, it's low risk. 10 to 20% is high risk. More than 20% is very high risk. And if the patient already had ASCVD, is extreme high risk. That's easy way to remember. You can add to it the cutoff values. You can add family history, CKD, diabetes, or additional risk factor. But what is required in class 1 is to bring down it to below 70. You also have 2B recommendation for billing at 40 in extreme high risk, but less than 70 is a universal across the subgroup with a very strong class 1 recommendation for patients with high risk categories. So risk categorization and usage is something that's strongly advocated. ACE 2025 algorithm is patient-centric. Its guiding principle remains shared decision-making via ACVD and other risk calculators, incorporating social determinants. Sections of overview is talking about risk assessment, lifestyle changes, pharmacotherapy escalation, and monitoring of ApoB every 6 months. Bempedoic as the first line non-statin for intolerant, achieving 18% LDL drop with caveat for uric acid rise, and diabetic focus if less than 70 for LDL from diagnosis as per the 2024 DCCT extension show a 30% delay in nephropathy as well. The cornerstone remains statin because of their HMG-CoA reductase inhibition. They achieve 30 to 50% reduction. Landmark trial like HPS, Prove It, TNT, all have established their role both in primary, secondary. I'm not even talking about Voskov's ABSCAPS and the previous generation of trials. They also did show, but HPS, Prove It, and TNT got it down to 70 where we know. So 1 millimole, which is 39 milligram percent of LDL reduction, would yield 22% reduction in MACE, and suboptimal control is very much common. Only 58% achieve the target. And so hence future use will emphasize lifelong adherence, early initiation, and combination strategies for the lipids. We know from the Fourier long-term data, Odyssey outcomes, DICES, dose density equivalent strategies of Atorva plus of 80 versus Atorva versus 40 plus ezetimibe versus CoQ associated myopathy group with coenzyme QRCTs. That patients with evolocumab plus statin achieve LDL less than 30 with additional 15% reduction, supporting lower the better outcome. Elaricumab added to rosuvastatin, another 21% reduction. Even 18% of high-risk patients with high intensity achieve in DICES study less than 70. It's the combination which achieves much better reduction, 52% reduction in better tolerability, and CoQ supplementation, 50% reduction in myalgia, and 85% symptom resolution after asymptomatic usage. Now, coming to the intolerance, myth versus reality, muscle symptoms are often overestimated. True pharmacological intolerance is less than 10%, which includes not only mitochondrial dysfunction, but genetic polymorphism and patient perception. Roswa and pravastatin and alternate regimes can improve tolerance. Non-statin therapy like PCSK9 and bempedoic are alternative to it. Patient counseling, gradual titration, and Indian experience highlights the need for the clinician education on managing the myopathy and statin-induced side effects. Beyond statin, ezetimibe have the intestinal absorption inhibition, leading to 20% LDL reduction. PCSK9, which is monoclonal antibody, alirocumab reduce it by 50 to 60%. Bempedoic reduces oral ATP citrate lyase inhibitor in statin intolerant subgroup. A silencer RNA therapy with biannual dosing has revolutionized the adherence. Early combination achieves faster, deeper control of LDL, and Indel formularies are increasingly including the FDCs with combination of these drugs. So we defining the LDL goal, PCSK9, they inhibit binding of the LDL receptor causes degradation, inhibiting the block with this interaction. Fourier and ODC have shown 15 to 20% reduction in MACE despite low LDL, achieving median LDL of 30 without major safety issues, reducing LP little a by 25 to 30% and TG by 10%. Long-term registry data of safety and sustained LDL reduction is there, and Indian adoption is slow due to cost and biosimilar production is under evaluation. So ESC 2025 talks about LDL lowering therapy and alternative therapies, where they clearly mention that those with very high risk LDL more than 70 or at high risk with more than 100, after lifestyle modification, one should think of statin in very high risk patients or very high risk patients with high or moderate risk or low risk patient despite lifestyle levels. Non-statin therapies like bempedoic is class 1B. Adding bempedoic to maximally tolerated statin with or without ezetimibe may be considered in very high or high risk individuals not achieving goal as class 2A. And evenocumab is class 2A level B in patients aged more than 5 with homozygous FH not reaching LDL goal on single therapy. Mixed dyslipidemia, which is an Indian issue. The Indian dyslipidemia profile, as we call, high TG, low HDL, and moderately elevated small dense LDL, driven by insulin resistance, high carb diet, visceral obesity, and Indians tend to develop CAD almost a decade earlier. Remap2 has shown 69% of diabetics have mixed dyslipidemia. Screening and lipid target achievement rates remain low, and need for regional guidelines and population-based lipid screening is recommended. So the ezetimibe dual pathway, it's acts on the Niemann-Pick C1 like transporter, blocking the dietary cholesterol uptake. We know from IMPROVE trial that simvastatin and ezetimibe reduce CV events by 6%. Additionally, especially beneficial in diabetic elderly and CKD, an add-on therapy for choice for statin treated but suboptimally controlled patient. Excellent safety cost profile. It's ideal for Indian setting and now recommended in all major global lipid guidelines. Bempedoic, as said, when added, it reduces LDL by 20% alone, 30% with ezetimibe. It acts exclusively in liver and then reduces the risk of myopathy. Clear outcome trial, 13% MACE reduction in statin intolerant patient. It's oral affordable and it's available in India. It's valuable in diabetic elderly and those with muscle intolerance. So combination therapies are here, and they are the future step. And we heard triple therapy, which is something that Dr. Dash already mentioned. Most high-risk patients need multi-agent regimes to meet less than 55. And statin, ezetimibe, PCSK9 yields more than 80% reduction. Early combination therapy is superior to stepwise addition preventing therapy. Uh, reduce the dose related adverse event were compared to high dose of single therapy. It's cost effective in high risk and secondary prevention. And new norm is now layered lipid lowering as a chronic management strategy, as Dr. Roy was mentioning. Lipid management in diabetes, this diabetic dyslipidemia, which is a problem, high TG, low LDL, low HDL, normal LDL, increased small dense LDL. Statin remains first line of choice for anybody more than 40 years. You add ezetimibe or PCSK9 if the LDL more than 7, still more than 70. Bempedoic for intolerant diabetic, especially TG lowering like eicosapentaol. It's a which reduces CV events and hypertriglyceridemia, dyslipidemia, and early and sustained LDL less than 55. It is important to reduce both macro and microvascular complication. So how should we go? There's no floor hypothesis for this. ESC 2019 talked about less than 55 and less than 40 for recurrent events. Sweetheart showed combination therapy achieved more than 90% goals. Ultra low LDL, which is less than 30, safe. No neurocognitive or hemorrhagic risk. LDL lowering early in life confers exponential benefits later. And in India, starting aggressive therapy earlier may offset younger CAD onset. Lipolitly remains a residual issue. More than 50 doubles the ACVD risk. Statin minimally affect it, while PCSK9 can reduce it by 25 to 30%. Pelacarsen and olpasiran are targeting the LP little by more than 80%, but their CVOT outcomes are still to come. Testing once in lifetime of lipolitly is recommended. Highest incidence is in Africa, followed by Southeast Asia. India needs population level screening and registry data for the same. So lipolytic and lifetime risk for MACE, as you can see, is linear, and this is in patients with 30 and those more pronounced with more than 50. So 50 is something that you need to look off. The Indian dyslipidemia paradox is a big issue here. There is predominance of high TG, low HDL, and both due to diet and genetics, and ApoB and non-HDL-C are hence superior targets over LDL. 69% of new diabetics exhibit this mixed dyslipidemia, and hence conventional LDL-based therapies, they underestimate the risk. So you need to incorporate TG and ApoB targets, and guidelines should reflect the ethnic lipid profile and lipid phenotypes. Dietary modification of low saturated fat fiber, but more importantly, the carbs. Carbs is a big problem in our part of the world. Plant sterols and soluble fiber would improve lipid modestly. Red yeast rice, berberine have statin-like mild side effects. Regular aerobic exercises raise HDL, lower TG. Indian diets are rich in carb, which need to be moderated, and lifestyle measures would amplify these pharmacological effects. In CKD, lipid lowering essential even with normal LDL, because these CKD patients, they primarily have cardiovascular deaths. Statin ezetimibe reduce the CV mortality up to stage 5 pre-dialysis. PCSK9 inhibitors are safe up to 30 GFR. Bempedoic acid is favorable in moderate renal dysfunction. Lipid goals enhance in all CKDs below 70 and less than 55 if they have ASCVD. There are ongoing trials of renal protection beyond lipid control with various drugs. So gender specific issues are women are underdiagnosed, undertreated because of perceived protection. Lipid rise steeply after menopause. Statins equally effective, but adherence is a big issue. PCSK9 inhibitors offer similar efficacy in both the gender and hormone replacement of alters lipid fraction but not AVS-CVD outcome, and hence the replacement therapy is no more considered. Indian women face compounded risk due to low screening risk, and inflammation, as Dr. Roy had mentioned, is a big issue in our part of the world. Even at LDL of less than 55, there is residual risk. CANTOS trial with canakinumab, which was anti-IL-2 and 6 inhibitor, proved that its benefits are beyond LDL. We know this from colchicine, both from Colcott and Lodoco-2 trial, which reduces event by reducing inflammation, though we had one negative trial recently, but these two trials still hold a strong ground. HSCRP, IL-6 are emerging actionable biomarkers. Statin and PCSK9 have partial anti-inflammatory action, and future lipid therapy may include dual lipid as well as inflammation targeting in future. Lipidology, the next leap is going to be integration of AI and genetics. Genetics and omics, the data allows stratified risk management. Genotyping with PCSK9, LDR, and ApoE identifies therapy responder. Lipidomics profile detects residual risk unrecognized for the LDL levels. AI-based modelings, especially I-Find studies, have looked into LDL response and adherence behavior. Multi-omic integration with personalized therapy by ethnicity is the need of the hour, including India's genetic diversity, where probably if CSI and Dr. Roy is here, if he intends to take that as the next leap from AI point of view in whatever way I can be of value, I'll be more than happy to contribute my little steps in that journey towards integrating AI in lipidology. India's genetic diversity offers unique opportunity for lipid research leadership. So to summarize, as they say, lower earlier, but smarter. You can't just be lower earlier. You need to be smart. You cannot have a blanket therapy for one and all. It's an evolving science, lipidology, which is going to be getting to a more precision level, driven by both genetics, AI, and omics, including risk stratification. Earlier, deeper LDL lowering, lifelong atheroma burden reduction can show 50% risk reduction when started early. RNA-based gene silencing drugs, just as I mentioned, pelacarsen, and more importantly, gene editing, which is already published now, CRISPR-based modulation. This time they've done with NHPTL3, and it has shown that 80% reduction in the lipid levels. Cost optimization, equitable access with real-world adoption, and is something that is determining how quickly advanced therapies can penetrate middle-income countries and countries like India. An integration of lipid control into holistic cardiometabolic prevention, where you target not only lipids, but you look at BP, glucose, inflammation, all the modifiable risk factors that can be addressed in the whole or perspective. So thank you very much. That brings me into my presentation, and I think we can have uh, 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 question answers at the end of the session with
Right.
Dr. Debarat.
Yeah. So thank you so much, Dr. Sharma, for such a wonderful presentation, and thank you for highlighting the scientific updates, the scientific evidences, the latest scientific evidences in terms of guideline-driven strategies for lipid management, the recent trends. Now we will move on to the questions from the audience. Uh, yeah. So, uh, there is one question, sir, Dr. Sharma, if you can answer. Uh, uh, what is your approach to patients who reach LDLC goals but have elevated TG, ApoB, or LPA?
Yeah, so as we know, targeting LP little a, whether it translate into outcome reduction by a therapy is not known. We know that LP little a increases the occurrence, but a therapy will, whether it will lower it or not, by lowering it, will it translate into event reduction with pelacarsen is yet to be shown. We know that it's a effective therapy, but it's not available. So the best way right now is to maintain and try to attain the LDL goals as low as possible. And on top of that, you need to think additionally to lower TG or non-LDL goals as well. And especially in Indian subset, the simplest way that I do when, because you cannot do lipid electrophoresis, is to look at TG HDL ratio. If your TG HDL ratio is more than 3.5, you are dealing with a small dense LDL. So in that case, your goals need to be even lower. You need to go lower than whatever risk you're looking at. TG modification is also important. If you look at the subgroup analysis of ASCOT trial, ASCOT LLA trial, in patients whose TG was 208, in that and above, even in that subgroup, fibrates were effective in reducing event rates. So it goes on to say that though we don't have a blanket guideline for TGs to be addressed, but we do have evidence that TGs, when treated appropriately in some certain subgroups, you actually do get benefit. So once the LDL goals are met, and TG is still more than 200 or 208 as was the cutoff, I even think of chasing them. But of course, in the order of the drugs that have been mentioned, I've done statins, I've done ezetimibe, not coming at, as Dr. Debarat Roy mentioned, adding bempedoic. Still not done. Why not? You need to go in with fibrates. If you need to go with icosapent you may go on 5 drugs or maybe a PCSK9 if the patient can afford. But I think it's a holistic, complete picture that needs to be addressed. PCSK9 have an advantage that it will lower lipolitl as well. But remember, lipolitl more than 50 for sure, 30 to 50, you don't need not. I mean, it's the evidence is not so robust. But once in a lifetime, you probably need to know. And if your LP little a is high, you go more aggressive in LDL because that's more scientific. Dr. Roy, you have any comments, sir?
Yeah, I fully agree with you that there are no trials so far that has linked LPA therapy, any form of LPA therapy, with event reduction. So in such cases, as you have outlined, it is we may go more aggressive. And what I believe that we can use right away with a triple combination of high intensity statin, bempedoic acid, and ezetimibe. That might be a very justifiable initial strategy. And if again the LDL goal is not achieved, and these patients may be treated as extreme risk or very high risk patients, and uh, yeah, and may these are the groups that may need other therapies in the form of PCSK9 inhibitors or inclisiran. And if you ask me that which one to choose, I will choose inclisiran because inclisiran has some role on LPA reduction as well.
Right. Yeah. So thank you, Dr. Rai. There is one question with regard to LPA. With the updated ESC guidelines recommending once in a lifetime LPA testing for all adults, how should clinicians practically implement this in routine practice first? And how aggressively should LDLC be lowered in patients with elevated LPA, even if their LDLC is near guideline targets?
See, you have to see at the reality in India. Let me tell you about a trial where Dr. Nakul Sinha and Dr. Ajit Mulaseri, they were the principal investigators. Right now, I cannot recollect the trial. I mean, exact the journal and the year. But what the trial showed that those patients who are started only on high intensity statin, if it is atorvastatin, only I think some 28% they continue taking atorvastatin at that dose at 1 year. And with rosuvastatin, it is even lower. So this is the Indian reality. Okay. Now, there are many things that how aggressive we should go. Should we do LPA screening as a population-based strategy? Given all the papers that has shown that LPA is indeed a risk factor, a risk amplifier rather, not a risk factor maybe, but definitely a risk amplifier for South Asian cohort. Now, the question is, even if your LPA is high in an asymptomatic 28-year-old with a LPA of 70, what are you going to do? This is a question.
Right.
So I think it is always because of the ground reality in India. It is justifiable that you start with statin when indicated based on the standard uh, guidelines. You advise lifestyle modification. And I can tell you another trial which has shown that with lifestyle modifications, the reduction in events is even more than with all these therapies, lipid lowering therapies or your blood pressure lowering therapies or your diabetes lowering therapies, if you do it properly. So I think this should be the strategy. So each and every patient who walks into your chamber with any cardiovascular complaint, because most of these young patients, uh, they sometimes they come with problems typical of coronary artery disease, which should be treated aggressively and which should be regarded as very high risk patients and should be managed accordingly. But for others who walks in your chamber, maybe with some dyslipidemia or diabetes or hypertension without any evidence of coronary artery disease, it is better to check the lipid, go accordingly, and advise us lifestyle modification and ensure that they adhere to that. Okay.
Right, sir. Uh, There is one more question to Dr. Roy, sir. How do you practically decide between the dual combination, for example, statin plus ezetimibe, versus the triple combination, statin, ezetimibe, and PCSK9 inhibitor, for example? Uh,
First of all, I don't consider PCSK9 inhibitor at all because I have published my own experience in PLOS One in 2020 in patients. We have two groups, just head to head, atorvastatin 80 versus rosuvastatin 40, and in both the groups we have achieved LDL less than 50 at 3 months. That is the standard you do in any trial. This is number one. Number two, if you look at the Indian Heart Journal, there is a series of papers that has shown that probably in some cases, even with an atorvastatin at a dose of 20 milligram, can lead to an LDL less than 50. It is possible. So don't jump. The message is very clear. Please don't jump at anything. You give the high intensity statin to start with. Check the LDL at 3 weeks, 4 weeks, and then you proceed accordingly. Please remember, whatever you give in addition to high intensity statin, PCSK9 inhibitors, inclisiran, those all costly medicines, they are not going to address the inflammation that is very much there during that acute stage, right? And you should look at the LDL, but that LDL therapy, if it is started even after 4 weeks, it doesn't matter, because in any case, for the plaque regression to happen, it will take months. It's not, maybe it's not in days, it's months. Okay. And if you tell me for my patients, I'll start with high intensity statin. I'll see what is the result. Then I'll add maybe bempedoic acid, ezetimibe combination and see. I'd like to carry on the drugs which the patients they can take on long-term basis. Please remember, there are trials which have shown that if you don't keep the LDL under control during the entire duration, this is not going to give you any benefit. If your patient takes a single shot of PCSK9 inhibitors or a single shot of inclisiran, it is not going to be translated into real benefit unless it is maintained long term. There we have seen practices where the patients are being told after undergoing angioplasty that if you take a shot of PCSK9 inhibitor or inclisiran, it is going to reduce your events, which is, please do understand that it is not a fact. It is not based on any scientific evidence. Rather, it can give a false sense of protection. What will happen if the patient discontinues, your LDL goes up, and there will be events, right? And right now, CSI has started an all India registry, and I believe we'll also invite Dr. Sharma to join that all India registry, where we are auditing the prescriptions to see the prescription pattern, the treatment adherence and control of the four major traditional cardiovascular risk factors: hypertension, diabetes, dyslipidemia, and tobacco addiction. And I think with all the data accrued, it will give real insight to us about what is the ground reality in India.
Yes, sir. More than happy to contribute data to that. Thank you, sir.
Yeah, yeah.
Yeah, so thank you, Dr. Roy. And before we close, one last question for Dr. Sharma. Sir, statin intolerance is commonly reported. So what is the structured approach you would recommend for evaluation or any alternative therapy selection in terms of this specific patient population?
So as I showed, I think it's over-reported. If you're gonna, it's got a what we call the effect or nocebo effect, as you call. I mean, if you're going to discuss and tell your patient with beta blockers, you're going to get erectile dysfunction as a possibility, the incidence is more. Same is the case with statin. If you discuss with your patient that there is a possibility of myalgias, there is self-reported incidence of myalgias is much more. I don't mean to say that you don't discuss this with your patients, but it often needs to be confirmed that you don't have enzyme elevations, and it's the patient can be explained that this may be a nocebo effect rather than a true myalgia. But if it is the case, a lot of times vitamin D coenzyme Q supplementation can work. On top of that, you can use, as we discussed, statins, which are better tolerated, like pitavastatin. But more importantly, bempedoic acid is one of the documented therapy that's there in clear outcome trials to show that you can use this as an alternative therapy. But remember, this was only in intolerant patient. Apart from that, we already have PCSK9. Often, when I'm actually not using statins, because of one or the other reason, I never use bempedoic alone. I often tend to combine with ezetimibe because the efficacy of lowering is much lower with either of the two drugs alone without statin. Both of them do effectively lower LDL more when they are used with statin. So if the patient is statin intolerant, I do tend to combine these two. I think that's one area. I would request Dr. Roy to probably look into that aspect as well, that whether it's a good strategy when not using statin, we can actually use upfront these two drugs as a combination therapy where we can't use PCSK9. So that's the other strategy that I use. But as Sir was mentioning, there's nothing like PCSK9 if you can give in a patient who already had an ASCVD. We have good data to suggest, and we also know that in TNT trial, if you stop statin within a month of discontinuation, the recurrence rate of another ACS event was as high as 80%, very high. This is something like antiplatelets. You stop and aspirin, clopidogrel, or for that matter, ticagrelor, or the number of events that you probably get, it goes up from 56% to 80%. That's a huge number. So statin discontinuation is also probably to be emphasized very strongly, which is not the message that goes. A lot of time our residents and our fellows, they'll say to the patient, ye do goli band nahi karna. And unfortunately, it is not the statin. They will mention aspirin and P2R12 inhibitor. But I think they have to tell even the statins need not be discontinued. So as I was mentioning, it's very important to make sure that the statin adherence and continuation is cross the timelines that the patient is supposed to take.
So, uh, thank you, sir. Thank you so much. Uh, and as we are about to end this episode of Lipitas lecture, on behalf of Nexa Division of Intas Pharmaceuticals, I extend my heartfelt gratitude to all of you for being part of these enriching sessions of Lipitas lecture series. A special word of thanks to our both the esteemed speakers, Dr. Roy and Dr. Sharma, for such thought-provoking perspectives on lipid management and cardiovascular risk, and highlighting the critical insights as far as the role of triple combination in high-risk ACS management, and Dr. Sharma for highlighting the changing trends in lipid management. Sir, your expertise and clarity have added immense value to our today's discussion. To all our attendees, thank you for your time and engagement. We hope that this platform continues to support your clinical practice and practice with the meaningful science and expert collaboration. With this, I wish you all a very pleasant evening and very good night. So, thank you once again. Thank you all.
Thank
Good
you. Good
night. Good
night.
night, sir. Have a lovely
And
weekend. Take care. Bye bye.
yeah, uh,
See,
yeah,
see you,
Dr.
sir, at
Sharma.
CSI.
Yeah,
Yes,
yeah.
sir.
One, can I have your mobile number, please?
Sure.